So good morning, everyone. My name is Lauren Chamberlain. I'm one of the child neurology residents here at Duke, and I'm going to present a case that I thought was pretty interesting. So this is a 40-year-old male, history of bipolar disorder, polysubstance abuse, schizoaffective disorder, seizures on lamotrigine and valproate, who presents with 10 days of right-sided weakness, difficulty ambulating, and confusion. So he talks about how his speech sounds a little more stuttered. He's having a hard time finding words, pronouncing words. In the past 10 days, he's also fallen about 7 times. It's also important to know that about 1 month prior to presentation, he was started on lamotrigine for about a 10 to 12 minute episode of confusion, combative activity that was concerning for seizures. So his primary neurologist has actually started the lamotrigine. And then 2 weeks prior to the symptoms starting, the dose is increased for frequent right arm twitching and concerns for seizures. So on presentation, his physical exam, vitals are stable. He's otherwise well appearing, he's oriented. You do hear a little bit of mild dysarthria. He does have some nystagmus at horizontal end gaze, as well as some mild weakness in his right deltoid and hip flexor. And he also noticed some ataxia with finger to nose and some truncal ataxia as well. On sitting on the bed, he just can't kind of sit straight up. He's leaning a little bit to the right. So with this presentation and the physical exams, we decided to get some imaging. So on MRI of his brain, that was otherwise normal. MRI of his cervical spine showed foraminal stenosis of C3 to C6. This didn't really explain his symptoms, but it did show something else. He had a heterogeneous mass adjacent to the left carotid space and inferior left carotid space. To further clarify what this mass was, we then ended up getting a CT soft tissue neck, which showed a 2.2 centimeter tissue mass in the left piriformis sinus, likely to represent HPV-associated squamous cell carcinoma, which spread to his cervical lymph nodes. And then the pathology confirmed that it was indeed squamous cell carcinoma. So I wanted to show the imaging as well. These are his MRI imaging. We look at a lot of MRIs. We really just focus on the spinal cord, the brain, things like that. But it's also good to note that you can see kind of the left compared to the right. At least this stands out when I make the circle. And then on the right, where his sagittal imaging, you can see that it's actually pushing on his airway too. So this is the mass that they're talking about. So now it's about 3 days into his hospital course. And what we have done so far is the right-sided twitching, we had an EEG placed on him, and it didn't show any correlation with abnormal brain activity. So with the fact that he was on lamotrigine and valproic acid, we were worried about lamotrigine toxicity. So at that point, we discontinued the lamotrigine. We're pretty confident that what we were seeing and what it was increased for wasn't in fact seizures. So we were thinking that maybe this is lamotrigine toxicity. And then at this time, we also had the mass suspicious for malignancy. So with the new onset of neurologic symptoms and this mass, we also started to think about paraneoplastic syndrome. So we looked at some articles, and we actually found one with paraneoplastic syndromes associated with laryngeal cancer. This is an article published in 2019. And basically between 1963 and 2019, they identified 59 cases of paraneoplastic syndromes associated with laryngeal cancer. Of those 59 cases, 46 were squamous cell carcinoma, and of the 59, 8 presented with neurologic symptoms. So some of the neurologic symptoms that they presented with were ataxia, jerky movements of the arms and legs, slurred speech, and nystagmus. So pretty much everything that our gentleman had. They also concluded that because of how rare it is, so basically 59 cases in 56 years, that paraneoplastic syndromes associated with laryngeal cancers are difficult to diagnose. So with that in mind, we thought maybe it wouldn't hurt him to go ahead and do some treatment. So it was about day 2 of Plex where we started to get some of the labs back. So on presentation, we got a lamotrigine level because we were worried that it was toxicity. That was normal. CSF studies were also normal. And then day 2 of Plex, he's actually having some improvement. So we thought, oh, definitely we would see an antibody. And no, his paraneoplastic panel was negative and other panels were negative as well. So what continued to happen was, since he was finding improvement from the plex, we decided to complete the 5 cycles. He had significant improvement. We actually were able to discharge him with no nystagmus, full strength, and actually better ability to walk and just a little bit of mild ataxia. So from his standpoint, he looks like he was paraneoplastic. We just didn't have an antibody. And I didn't like how this kind of case presented out, because I thought that maybe definitely we'd have an antibody. We can say for sure that this was associated with the mass and things like that. So I looked for some other studies to kind of explain how difficult it is to diagnose. And I found a study that goes ahead and helps with the practical approach of diagnosing paraneoplastic neurologic symptoms. And actually, this study had showed maybe 30 to 40% of cases actually don't have an antibody associated with it. And Dr. Kenneth, who actually presented this study in the Indian Neurologic Journal, showed this great algorithm that I really wanted to share with you guys. I thought this was a better thing to share than the pathophys of paraneoplastic syndromes. So if we use our case and we go ahead, we did suspect paraneoplastic syndromes. We went ahead and we did the panel of antibodies. It was negative. At that point, we didn't have an alternative diagnosis. Our imaging didn't really show anything. Our lamotrigine level was not toxic. So now we basically do what we did. So that's good to know that we go ahead and screen for cancer, which we were doing. He was getting in touch with ENT and the neuro-onc people. And then also we trialed the immunotherapy, which he actually improved on. So I thought this was good to know that even not having the antibody, we still would have got to the treatment that helped him. So I haven't really followed up on him. He does have an appointment coming up with, I think, Dr. Morgan Lander in a couple weeks. And for his cancer, they planned on doing radiation, just because they try really hard not to resect these, because usually with resection, people end up with a trach. So hopefully he'll continue to improve and he didn't regress. And if he did, then we can try maybe some more immunotherapy for him to help. And that's it.
Thank you, Lauren. That was wonderful. Now to introduce our Grand Round speaker, I'm going to hand it over to Atif.
Thank you very much, Rich. It's a pleasure for me to introduce today's guest speaker, today's Epilepsy Grand Rounds. And so our speaker today is a very well-known neurophysiologist and epileptologist. He's joining us from Göttingen, Germany. Dr. Walter Paulus is presently the president of the International Federation of Clinical Neurophysiology. Walter is a world-renowned neuroscientist and researcher in non-invasive brain stimulation, and really is the one main leader one looks to when you look at non-invasive brain stimulation. Just a little bit of background about him. He grew up and went to school, University of Dusseldorf, received his doctorate from there, studied there some more, and ultimately went to the National Hospital for Neurology and Neurosurgery in London, where he got additional training, ultimately coming back to Germany, and in the early 1990s came to where he is now, which is Göttingen, and was appointed chairman of the Department of Clinical Neurophysiology. Walter now is the last remaining chair of the department of, in any department of clinical neurophysiology in Germany, and has been running that department for now about 25 years. I was struck that Bert has published on retinal findings that Rich talked about today. Indeed, Walter's original PhD work was on color perception and retinal color circuit models. So I think there's some perhaps irony there. But what Walter has really been famous for and well known for is his work with non-invasive stimulation, particularly transcranial direct current, or TDCS, as well as other types of stimulation, such as alternating current stimulation, transcranial noise stimulation, and others. As I was researching what I would say about him today, I Googled him, and I found, much to my surprise, that he has his own Wikipedia page, which I did not know existed. I don't know if you know exists, Walter, but you have your own Wikipedia page, which gives a lot of useful information. We don't know if it's correct or not, but that's what I'm going on. But currently, as I said, Walter is a professor of clinical neurophysiology, and something we should learn from is a chairman of the Department of Clinical Neurophysiology, which the Europeans have figured out is the way to do it. He, as I said, is currently the president of the International Federation, has previously been the president of the German Society of Clinical Neurophysiology, as well as the president of the European chapter of the International Federation. So with that, I'm going to turn it over to you, Walter. Again, I appreciate you joining us from your office in Göttingen, and telling us about brain stimulation and epilepsy. Thank you very much.
Atif, thank you very much for this kind introduction. Good morning to everybody. So let's start. I will release the screen. So, yeah. Okay, yeah. So you should see my presentation now. Non-invasive brain stimulation in epilepsy. I have one conflict of interest. I'm in the scientific advisory board of this company, and they are just, they have started to do a study trial in epilepsy patients with a kind of semi-invasive stimulation technique, so applying electrodes between skin and skull. Since my talk is entirely devoted to non-invasive, I will skip that then. Now, let's start with TMS as a diagnostic tool. I referred to this overview some 4 years ago in Clinical Neurophysiology. Of course, the technique of transcranial magnetic stimulation with all the variants allows us to assess excitability of the brain also in epilepsy patients. And so what we can do, usually we can simply standardize the intensity of the magnetic stimulation, and then we have a single pulse, or here we have a so-called silent period. We have a pre-activation. You see noise in the background of the muscle, then the response is recorded at the muscle, and then we can, by a suprathreshold pulse, induce a silent period. And then we have paired pulse techniques. I have not much time to go into detail here, which end up either in inhibition, which is certainly generated in the cortex, or excitation, depending on the interval between the conditioning subthreshold and the suprathreshold test pulse. Now, just to summarize it, what comes out in epilepsy over the years. So we have an increased excitability in drug-naive epilepsy patients, most prominent for generalized epilepsy, and there is a trend towards a lower resting motor threshold and a prolonged cortical silent period for generalized epilepsy. This is a paper having published in 1990, and the conclusion from the authors was we can activate by TMS an epileptic focus. So they applied a stimulus, and then they claimed that this selectively activates the focus, and this turned out to be wrong. You see here the seizure was already ongoing, and if you look into more detail here, you can see if you apply a TMS pulse even during a seizure, you can certainly interrupt it for a short time. So nevertheless, we were motivated at that time to replicate that. And so we did a transcranial magnetic stimulation study in patients with mesiotemporal epileptic foci. And to make a long story short, we ended up with less epileptic activity. So going down rated per minute from 3.5 to 1.7. So the conclusion was we had no significant spike activation and even observed bilateral reduction of epileptic activity in some patients. And I come back later that we were a few years earlier, before Robert Chen introduced well-cited 1 Hertz activation TMS pattern for generating inhibition. Now, one slide for safety. So this paper summarized seizures from transcranial magnetic stimulation for 4 years. This is a result of a large survey. 174 labs were questioned, and they came up with 24 seizures, 16 originating in the primary motor area, 7 prefrontal, 1 parietal. So the subject risk factor increased substantially if you have, for instance, a brain lesion and epilepsy. We have seen one actually during a diagnostic TMS procedure in a patient with focal epilepsy due to a brain tumor. Now the risk is very low, so you have to do 10,000, roughly 10,000 sessions, and then you get 1 seizure. And interestingly, the high frequency seizures or high frequency patterns are no more likely to cause seizures than low frequency if you come up with a lesion before. Now this is recent, just appeared a few weeks ago, update on the recommendations for TMS use in healthy subjects. And what is really important to be aware of, if you have supra-threshold, refer to the motor threshold. Repetitive stimulation at higher frequency, so let's go to 20 or 25 Hertz, then you can stimulate only less than a second without having a risk of seizures. If you stimulate with this low frequency inhibitory stimulation, you can stimulate deliberately long, depending on intensity. So these safety criteria were fixed some 20 years ago, and the reported seizures in lab environments dropped substantially. And just one link to magnetic seizure therapy, of course, electroconvulsive therapy can be done by magnetic stimulation. You need higher intensities, and after a few seconds, under narcosis, you can induce a seizure in depressive patients. Now, just a comment to pharmacological actions of anti-epileptic drugs detected by TMS. So our early work was facilitated by a dystonia patient claiming that he got rid or substantially reduced his dystonia by alcohol. And we did this first study in 1995, and then immediately after a similar study with lorazepam. And what essentially comes out is, if you use this so-called SICI paradigm, short interval intracortical inhibition, then you can see if the conditioning stimulus is within the first 5 to 7 milliseconds before the test stimulus. The test stimulus is inhibited, and more by GABAergic targeting drugs. And the facilitation, which you see with a longer interval of about 10 milliseconds, is also reduced. So you can really objectify the efficacy of anti-epileptic drugs, and to some extent also refer to the mechanism. And this is shown in this slide. This was published in 1998. And we looked at 6 different drugs. So 3 drugs targeting inhibition via GABA acting drugs, so vigabatrin, gabapentin, baclofen, and here you see the sodium channel blocking drugs, and this is carbamazepine, lamotrigine, and losigamone. And you see that the motor threshold here, this is the active motor threshold, and this is resting motor threshold, which is always higher, is not affected by GABA acting drugs. But if you apply a sodium channel blocker, and please be reminded that at the axon hill, of course, sodium channels determine if a spike is generated. So if you apply, for instance, carbamazepine, you see that with a single dose, you have an elevation of the motor threshold up to 48 hours. So elevation of motor threshold by sodium channel blockers and no influence by GABAergic. So we summarized that a few years ago. There are more data in the meantime. So we have a lot of parameters. So motor threshold, motor evoked potential, cortical silent period, and this short interval intracortical inhibition, intracortical facilitation, and they are all in a way a little bit related to some mechanisms of communication of cells in the brain, and just want to figure out this GABA agonist, so all the benzodiazepines and as I mentioned, vigabatrin and other drugs. So you see, they are, you can use as a biomarker then the silent period and the inhibition and the facilitation, as I mentioned. So this is a huge area. Now let's switch to RTMS as a therapeutic tool. I will provide a simpler, complex, and a pragmatic view. Why do we need it at all? Of course, we have still a substantial amount of therapy-resistant patients. You know that as well, and we fight every day with therapy-resistant epilepsy patients. What is needed if we go for transcranial methods, we need an outlasting inhibition of the brain. So this is a disadvantage as compared to the implanted systems. This is an overview from Cartarone some 14 years ago. So they compared repetitive TMS, theta burst stimulation, paired associative stimulation, and TDCS. For inhibition, which is the goal for epilepsy or depression, where you want to have an increased excitability. So let's start with the first one, RTMS. This is again Robert Chen's study from 1997. So if you apply every 10 seconds a suprathreshold stimulus at the motor cortex, you see that the motor evoked potential is not altered. If you apply it at 0.9 hertz, they were not allowed to go to 1 hertz by the ethical committee at that time. So you see that during stimulation, you start up with a decline. And this is the after effect. And the after effect lasts usually with this paradigm up to 30 minutes. So this is the most modern view at the moment. We have at our availability a so-called controllable pulse stimulator. You can modify the pulse width, and you can play around with biphasic and monophasic pulses. And what you see here, with a pulse width of 40 microseconds and 80 microseconds, we can reproduce this inhibition. But if you prolong the pulse width to 120 microseconds, it switches to excitation. So this is another tool now which hopefully will allow us to generate more specific inhibitory and excitatory after effects. By the way, this device was developed by Angel Petershev, who is working next door to you, and his co-worker is now developing an even more flexible stimulator, which does not require compensatory phases. So hopefully the next generation is also already ahead. So just a hint. In 1999, we started a trial with 9 patients in epilepsy. So we stimulated with 0.3 hertz, 1,000 stimuli a day for 5 days, and we saw a reduction in seizure frequency by some 30% for the following weeks. And we did a replication study now in 28 patients, also 5-day stimulation around call, just subthreshold. And we saw for the first 2 weeks, we saw a reduction in seizure frequency also, and as compared to, so this was a 0.3 hertz stimulation as compared to 1 hertz and placebo stimulation. This is a paper published in Clinical Neurophysiology also last year. If you look for all studies, you can identify 47 papers in epilepsy. Most are not sham controlled. Most have less than 10 patients. So there is not sufficient evidence to recommend that in the moment for routine use. So there is a possible efficacy. Now let's quickly go to theta burst. There are no, to my knowledge, no theta burst therapeutic studies in epilepsy. This is taken from a huge antidepressive trial, which of course then uses excitation. And most interestingly, you see the conventional protocol with 10 hertz stimulation for excitation in depression is as efficacious as a much shorter theta burst paradigm. So this compares 37 minutes versus 3 minutes. And if that would apply for epilepsy as well, then we could shorten the Chen protocol from 15 minutes to 40 seconds. Now, next one is paired associated stimulation. So the usual protocol is you stimulate the median nerve, wait some 25 seconds until the volley arrives at the cortex, and then you apply a TMS pulse here. Then you end up with a similar excitability increase measured again with single pulse TMS over time at the motor cortex. What we did some 20 years ago, we had a colleague here, Christoph Kott, who left unfortunately for the Epilepsy Center in Freiburg. So he was able to detect the spike online, and we did a paired associative stimulation, putting the TMS pulse on the top of the spike, and only in 2 patients. We saw a slight increase of the motor invoke potential at the motor cortex, and vice versa. If you put it on the wave, we saw a reduction, and you had to give it up at that time and didn't take up it for 20 years. But so if the other problem is that not rarely you do have clear, in at least focal epilepsies, clear spike wave complexes in the surface EEG to pursue that approach. But I think this is a very interesting tentative method to dampen epileptic activity in the cortex. Now, transcranial direct current stimulation. Michael Nietzsche and I published this study in 2000. If you apply 1 milliamp TDCS and nodally at the motor cortex for 5 minutes, and then you probe again the motor evoked potential with TMS with the same intensity, you see that you have a larger motor response for a few minutes. And if you reverse stimulation here, then you put the cathode at the motor cortex, return electrode at the front head, then you see an inhibition. And this is, of course, very interesting if you could pursue that in epilepsy. The first assumption is that the longer you stimulate, the longer your effects last, and this is wrong. So at 2003, we thought this is the after effect of a 9 and 11 minute stimulation duration that you see you can generate inhibition for an hour or so. But if you prolong it even more, and there I will show these data in a minute, it may switch up to excitation. So this is a complex and difficult area. And I just want to mention this paper from 1995. So quenching inhibition of development and expression of amygdala kindled seizures with low frequency stimulation. So in rats, 1 hertz for 15 minutes, seizures were going down. 3 years later, the same group published this paper, quenching revisited low-level direct current inhibits the seizures. So they could not replicate the finding, and noted that some of their stimulators had a cathodal DC offset, and this was responsible for the effect. So you have to be very careful about your equipment. Could mention a lot of aspects there. We did a study in rats in 2006. This is a ramp model which was suggested by Wolfgang Löcher, an epileptologist from Hanover. And you see here, if you apply in a rat epilepsy model anodal stimulation, nothing happens, which is a good sign. So no increase of the seizure or decrease of the seizure threshold. And if you apply at 100 microamp, which is low, adapted to the rat brain, you see no effect after 30 minutes, but you see an effect after 60 minutes. If you go higher in intensity, then you can already see an inhibitory effect in the rat at 200 microamp after 30 minutes. So in a way, time and intensity may be exchangeable. One of the first clinical trials were published by Pragmatic and Pascalione's group, 19 patients, 1 session of cathode DC polarization, 20 minutes, 1 milliamp. And you see here there was a reduction in the seizure frequency and also in the epilepsy specific potentials over time. There are other, I will only mention as an example, other studies from Thailand. This group saw a decrease in epilepsy typical alterations in the EEG, but not in the seizure activity. And this was summarized 3 years ago again, so no recommendation can be made about the potential efficacy of TDCS in the treatment of any type of epilepsy at the moment. And this was another recent overview. So how can we tentatively increase the efficacy of cathode stimulation? We published that some 10 years ago, and what you see here, this is the inhibitory after effect, again measured at the motor cortex, inhibition of the motor, evoke potential over time, so for an hour, and then you see a slightly longer inhibition if you double the stimulation duration to 18 minutes. But you can substantially prolong it even more if you introduce an interval either of 3 minutes or of 9 minutes. So you have 2 blocks, 9 minutes cathode stimulation, then you wait for 20 minutes and then again 9 minutes. And this was taken up by this Chinese group, and they just published this last year. Yet you see here a group of 70 patients, parallel group design, 2-week stimulation with 2 milliamp. This is a sham stimulation group. And you see here the group 2, 20 minutes continuous TDCS at 2 milliamp. So the effect fades away after about week 6. At the group 3 with the split paradigm, twice 20 minutes, had a lasting effect for 10 weeks. So this is the most promising approach at the moment. This is just appeared a few days ago in brain stimulation. What happens if you have seizures during transcranial direct current stimulation in patients with epilepsy? So 5 patients have been described. The trials were stopped, but the patients did not need any emergency medication. So this seems to be safe as well. Now, let's mention a little bit the complexity of all this. We looked at the motor cortex stimulation in the PET scan. It's now quite difficult to do or to replicate this type of study simply because of the radiation involved. So these are normal subjects. You see here the motor cortex electrode at a high cutoff level of analysis. This is probably a vascular effect. Stimulation motor cortex return electrode at the frontal area, but most interestingly, you see a widespread activation and deactivation all over the brain. And of course, we can target remote areas. And the future is, of course, that we identify epileptic network with, especially in otherwise therapy-resistant patients which are not where you cannot perform an operation of one foci. So a multi-channel stimulation is ahead in the future by using many electrodes and developing paradigms to stimulate simultaneously or alternatingly at different areas. Now, what about unwanted and nodal excitation? Please be reminded, if you use electricity, you need always 2 electrodes. And if you use direct current, you need already, of course, not only inhibitory cathode electrode, but you need also an anodal electrode. If you go to the slice, then for instance, you have here an anodal electrode and here a cathodal electrode. And here you have the reverse effect as compared to here. So, or let's assume you have an epileptic focus where this may extend across a bend of a gyrus. So on the one side, you have a cathodal inhibition, and inevitably on the other side, an excitation. Now, one very interesting possibility is simply to block excitation by drugs. And you see here, this we published 18 years ago. If you co-apply during TDCS carbamazepine, the N-nodal after effect collapses and the cathodal remains. And the same applies with flunarizine, a calcium antagonist. So you see here the after effect under placebo drug, and then you apply flunarizine, so it collapses, and then you have no influence on the inhibitory effect. So this is one approach for the design of future studies. And this is taken from Alexander Rothenberg's group. He has an interest in glutamate. So he published 4 years ago. First author is Sun. Direct current stimulation induces mGlu R5 dependent neocortical plasticity. And just a few months ago, they published this paper. I have no time to go into detail here. This is the main message. So cathodal DCS reliably induced LTD in superficial cortical layers and a long-term potentiation-like enhancement in deep layers. And NMDR blockers, memantine and this experimental drug, either produce the more uniform long-term depression throughout the cortical thickness or at least abolished DCS long-term potentiation. So we have at least 3 drugs now in the pipeline which may prevent unwanted excitability increases. We can, of course, also boost inhibitory cathodal neuroplasticity. And this is taken from a study from Michael Nietzsche in 2006. If you co-apply pergolide, the dopamine receptor agonist, you see that the cathodal after effect, the inhibitory after effect, is substantially prolonged from 30 minutes to the same evening and even next morning, so more than 20-fold. So that we thought that is the solution. However, then we went to a co-application of L-DOPA, and at first glance you see a very interesting inversal of nodal excitation into inhibition and a substantial prolongation as well. So the inhibition lasts now not only 60 to 90 minutes, but it extends to the next day. But then we went to paired associated stimulation. So as I mentioned, you stimulate the median nerve and then you wait 25 milliseconds and then you stimulate the motor cortex. And then you see here, this is excitability increase, which lasts for 15 minutes. But then under L-DOPA, you have a boost of this excitation. And we think this is tentatively more related to epilepsy. Why? We think that the PAS induced plasticity is more synapse specific. So you pre-activate sensory income to the motor cortex, and then you superimpose a magnetic stimulation. And those synapses which are pre-activated by the sensory are now reinforced. And this is probably more related to what is going on in epilepsy. So we are probably not well, so this is not a good way to go ahead with. Now, let's quickly talk to the DCS versus alternating current stimulation. So, and what is the difference to RTMS? Please be reminded that the skull is a major inhibitory fragment for allowing the current to pass. So here we have the skin, this is the voltage, and this is the current flow. So here we have the skin, and the skull has a high resistance, low flow, and the CSF is full of electrolytes, has a high conductivity. So this distributes the skull, which may have an unwanted effect if the current enters the CSF, it does not go straight forward to the brain beneath, but it distributes widely. And this is different in RTMS. RTMS is blind for the skull. It goes unaffected through the skull. So this is an advantage of RTMS. Now we have other problems to deal with. This is a study from Michael Nietzsche's group. You see here the anodal excitation with 1 milliamp, cathodal inhibition with 1 milliamp. If you double the intensity, the cathodal inhibition switches to excitation. So we have a dosing problem. And less, maybe more here. And if you look at this skull thickness, this is a thick bone at the vertex, this is a thin bone temporally, which we use for ultrasound, and we have local thinnings. And what happens if you apply a large electrode, usually 7 times 5 centimeters, the skull is shifted to the border, so you have a ring stimulation. And then you see more current flow here with a thin bone, according to Ohm's law, less current flow here with a thick bone. And this is a local thinning, and you cannot predict where you have these variations in thickness. So if the motor cortex is here, you have a different stimulation as here, and this may also apply for the epileptic foci. So, and this has to be adjusted in children. This is a study in children from Vera Moliartse some time ago. You see here SHEM stimulation, and then you see 0.5 milliamp cathode. This is inhibition. And now if you go to 1 milliamp here, this is excitation, which is inhibitory in adults. So we have to be aware of that. And this is a very nice title from Holly Lisenby, just published as an abstract recently, Neuromodulation in Children and Adolescents, the devil is in the dosing. This is again from Michael Nietzsche's group, published in 2019. This is a 3-dimensional picture, the 1 milliamp, 2 milliamp, 3 milliamp, after effects, 15 minutes, 20 minutes, 30 minutes, and then you see different stimulation durations. So a very complex issue if you end up in inhibition or facilitation. And this is something also you should be aware of. This is at least in motor cortex studies, a well-known study by Peter Fox. So what he did, he looked at the activation of the motor cortex in the PET scan by finger tapping and by TMS. And what you see here, the activation is not at the crown, but mostly in the gyrus, independent of if you stimulate by finger tapping or by TMS. Now, what he argues, we know TMS can only generate tangential current flow. It cannot generate radial current flow. And just correlate to magnetoencephalography, the same arguing applies there as well. You can only record tangential and no radial generators. Now, what happens if you stimulate? You have a high current flow, tangential current flow here, but here's a CSF. The CSF is highly conducting. And the argument of these authors is it passes the brain, does not enter the brain. Here, we have less current flow. Let's say you go from 185 to 70, but it is entering perpendicularly. And so the argument is we are stimulating not the crowns, but the walls or close to the crown. And this was a calculation done by, again, Peter Todd Creek some years ago. All what, if that is true, all what is blue here cannot be stimulated by TMS. And this is again an advantage for TDCS. You can target deliberately any area in the brain depending on your electrode montage. Now, next point, how to reduce direction sensitivity of TDCS. We can, of course, go to alternating current. And you see, if I alternate from one electrode to the others, I do no longer have this directional sensitivity which you have with cathodal and anodal stimulation. And this is a study by Vera Mogliarze 10 years ago. So she stimulated again the motor cortex with 3 different frequencies, 140 Hertz, 250 Hertz, and 80 Hertz. And you see that this frequency has a build-up during 10 minutes of 1 milliamp alternating current stimulation at the motor cortex, again probed by motor evoked potential. And then you have an after effect. And this after effect is best at 140 Hertz and almost not there at 80 Hertz and much smaller at 250 Hertz. And interestingly, this is the experimentally found optimal stimulation frequency with square wave stimulation in deep brain stimulation in Parkinson's disease. And of course, we know that as epileptologists, so ripples are in this range up to 250 Hertz or so. Now, this is a situation at rest. Now, let's have a look at state dependency. What happens if you do the same experiment? This was in the same study. Here we have this 140 Hertz stimulation after effect. Now, we did a motor learning paradigm. This is implicit motor learning. You train a certain sequence, and then you measure the reaction time. And then you measure afterwards. Here you introduce a new sequence, and then you try to find out if you learned the train sequence. And here we have the reverse pattern. So 80 Hertz is better, 140 Hertz is not good, and 250 is now the best frequency to generate after effects for motor learning. So how can we bring that together? And please be reminded that, of course, epileptic discharges are per definition generated by brain activation. So we are more in that area as compared to the rest area. This is another study by Andrea Antal some 13 years ago. Here you see the n-nodal after effect, again measured by MEP amplitude, exciting, and you see here inhibiting by cathodal stimulation. Now, this is a situation where the subjects are at rest, so with an unoccupied brain. Now, if at the same time they have to fill in an intelligence test, the effect collapses with a tendency to reverse, both for the cathode and anodal. Now, if you apply motor tapping during this, you end up in inhibition and during n-nodal stimulation. So n-nodal stimulation in an activated area is inhibitory. And here we think this has to do with centers around inhibition. I cannot go into detail here with a limited time. And the cathodal stimulation is boosted. How can we bring that together? So I wrote this paper with John Roswell a few years ago. We think that the best cell to activate is a resting cell. So you activate the dendritic arborization somewhere, and then your excitation travels all along then the cell body and excites this axon at the axon hill. Now, if you activate the cell, this may be due by behavior paradigm, by, as I mentioned, attention, or by motor tapping, then of course you activate all the membranes around and they become leaky, and the activation you generate here may simply leave the dendritic arborization before it can influence the soma at all. And I have also no time to go into that. You can explain the time course of Zicki by shunting inhibition. So we know that if you have a subthreshold stimulus, you target preferentially more inhibitory neurons. So we think you first stimulate inhibitory neurons, it makes the cell leaky, and then you end up in inhibition. So now what is then the optimal DACS stimulation frequency? Very difficult to know that, but this may be a way to come around that. So if you stimulate the brain with random noise, so this is a frequency spectrum close to 0 Hertz up to 640 Hertz, then you can generate the same after effects as you can generate with 140 Hertz, 1 milliamp alternating current, or with 1 milliamp TACS. Now, what is the optimal intensity? And here we may say less intensity might be more efficacy. And we think that if you think in calcium concentration increase within a neuron, you first end up in LTD, and then you have a no man's land 1. This is a transition zone to LTD, and then no man's land 2. And if we now target inhibitory cells, we want to generate LTP in inhibitory neurons for inhibition. If we want to reduce the efficacy of excitatory cells, we need to be here. So this is a difficult to solve problem. We have data on that in both RNS and alternating current. I will quickly go through that. So if you have a low intensity 0.2 milliamp, you have no effect. We think we are below the LTD range, and then with 0.4 we are in the LTD range, and 0.6 milliamp, 0.8 milliamp, again no effect, and then you end up in LTP. I have also not much time to go into detail here. This is a modeling study by a group in New Zealand, Wilson. So what you see here, they look at theta burst, and we know that if this is a classical 600 pulse theta burst paradigm, which is inhibitory for continuous theta burst, which is excitatory for excitatory theta burst. And this reverses over time. The more pulses you have, this oscillating pattern. And if you look now, what is interesting for epilepsy at CTBS with the classical paradigm, we are here. We have a 50 Hertz paradigm. And so we have 20 milliseconds between 3 pulses here. And we repeat it 5 times per second. But we can play around here. So we can, let's say, go to here, then the burst should have then 6 pulses, and then we have multiple options which we can tentatively probe in order to get more reliable after effects. So let's quickly go to a pragmatic view. This is a coffee study, which Faisal Suklify published a year ago. And so we had the classical 140 Hertz TACS 1 milliamp paradigm. This is the sham stimulation after effect excitatory. And you see here with a true espresso, you see inhibition. And if you have a decaf espresso, you see also effect. And please be reminded that in coffee, we have about 1,000 different substances, and the discussed neuroprotective effect of coffee is probably not the coffee in itself, but other substances here. So espresso or coffee significantly modifies MEPs, but not epilepsy. So we have, what I'm going to say, we are very happy to have this framework with a lot of data for MEPs, but they may not predict what is going on in epilepsy. And the pragmatic view, if you want to go for an individual patient treatment, is follow established protocols. I mentioned some of these, learn some aspects from other trials. The most clinical studies we have from our psychiatric colleagues in depression, and what we learned there is that you should go probably to a 4-week stimulation, not 2 weeks, maybe too short to get reliable. So every day stimulation for 4 weeks, and then try to use sodium channel blockers in TDCS and some other aspects, as I mentioned. And I'm now out of time. I just want to mention that this focused ultrasound may be a future in just heating up the brain focally for neuroplastic after effects, and we may, with ultrasound, open the blood-brain barrier for drugs. And we will now, in this project, will combine high-frequency alternating current stimulation with simultaneous ultrasound to generate Lorentz forces deep in the brain. I thank all these people and many others, and I thank the funding organization. I thank you for your attention.
Thank you, Dr. Paulus. So for folks who don't have to run off, if anyone has questions for Dr. Paulus, just put your name in the chat and I'll call on you, or just speak up.
Was habe ich jetzt Jetzt habe ich Mist gemacht.
Dr. Paulus, I have a question. So the data that is cited most that TDCS or TMS can have a long-term effect is around epilepsy. Yet an objective person might believe that those weren't really well-blinded studies and the effect was modest. Do you want to comment on that?
Yes, blinding is a big issue. And if you talk about blinding in RTMS studies, it is very difficult to have a complete blinding. If you want to have a complete blinding, you need a co-application in the sham study with a small electric stimuli in order to blind the subjects also for the skin response. You feel it a little bit on the skin. If you go for electric studies, you feel a skin perception, a prickling sensation with TDCS. We try to blind it by having a ramping in scheme where we ramp in for, let's say, 10 seconds. You feel this prickling sensation, then we ramp it out, and then the end again. And we are playing around with short prickling sensations in order to get an even better blinding. If you go to, this is an advantage of alternating current and of random noise. If you go to alternating current and random noise, you have less skin sensations. You may blind it even better.
Okay. There's a question someone asked me to read, which the data suggests that there's such a huge variation in individual response to magnetic or direct current stimulation. How can trials really be done and take into effect that a couple people seem to carry such big benefits that it skews the trial?
I'm not sure if I got that question right. So how can
There's
I?
a variability in individual response to these.
Yes,
stimuli.
okay. Yes. This is also a very good question. And if you think about if this culture model is true and can be applied, if you have a thick bone with electric studies, you may easily be in a LTD or LTP range, and you want to target the other one. So if I would have sufficient resources, I would go for, in electric studies, I would go for a skull imaging. And here you can also discuss that the CT scan is better for bone imaging than any MRI technique, but there are MRI techniques which allow you to model that individually. And then you need to go ahead with individual computational models to find out the best paradigm. There is, by the way, a model, a program freely available, developed by Axel Teacher, SimNIPS. You can download it and you have a huge flexibility to generate your own individual current flow intensities.
Thank you. Simon, do you want to ask your question?
Sure. I just wanted to get your thoughts, Dr. Paulus, on the Brescia's group use of SICI and SAI, short afferent inhibition, on identifying Alzheimer's or frontotemporal dementia. I thought that was just your thoughts on that approach.
Well, we know from SIE, so you apply this afferent stimulation, and then you see how you can modify your TMS outread, that this correlates to cholinergic function. And there are quite a bit of data around that this can contribute to an early diagnosis of Alzheimer's disease or dementia, if this is a question.
Yes, but what do you think of the data? Do you think it's really?
Well, this is not my immediate area. But as far as I remember, I think at least on a group basis, the data are valid. The question always is if you can separate an individual patient out of a larger cohort.
You mean
I'm
so
not sure.
there are group changes, but can it be predictive for one person?
Yes, that may be, yes. But as I said, I would have to look into that again.
Okay, Dr. Parekh, you have a question?
Yeah, hi, Dr. Paulus. I was wondering, how would you, do you see the use of TMS in localization or in mapping instead of stereo EEG in the near future in epilepsy?
Yes, actually, we are doing this as a service for our neurosurgeons. You know you can buy devices which are sold for that particular purpose, and there is at least in Germany there is a reimbursement for that.
Oh,
So we have a robot here which is not CE certified, but we have a program which allows a robot to narrow the range of the motor threshold, at least in order to identify the motor cortex. And of course, you can also try to target the Broca's area by trying to inhibit fluent speech.
So you think it might replace WADA testing? Is that the idea?
Um, well, the main idea here is to allow the surgeons, if they operate, for instance, close to eloquent areas in the motor cortex, to allow them to identify the hotspot for the motor cortex.
Intraoperative.
The problem here is a little bit, yes, well, preoperative, yes. Of course, if they have a tumor there which needs to be removed, you have an operative mass shift, and the preoperative coordinates may no longer apply. And the other interesting aspect in the motor cortex is 90% of the motor cortex is in the wall. So the deeper the motor cortex is allocated, the less intensity, of course, as I mentioned, you have in TMS stimulation. And there is a new motor cortex deep in the wall, which is responsible for dexterity, which has the monosynaptic connections to the spinal cord. And there is an old motor cortex, polysynaptic, more at the surface. So a lot of issues playing a role there.
And we'll throw it back to Atif to end the wonderful talk.
Thanks very much, Rich, and thank you very much, Walter. That was excellent. I'll just make a couple of quick comments to Dr. Parekh's comment. The motor mapping is approved by the FDA as well, and there are units that are approved and available in the US. We actually are approved to purchase one of them and would have gotten it by now had it not been for COVID. So we will be in the business of mapping, and it's really only for motor mapping approved at this point, not for language and memory. Obviously, those are the issues that we deal with WADA as well. So more to come on that. But Walter, thank you very much. One of the things that I've been really interested in and wonder what you think in very quickly is the future of this is the value of TMS in drug development for epilepsy. So both your work as well as now Ulf Siemens' work in terms of looking at the anti-epileptogenic properties or not anti-seizure properties of various medications. Do you think there's value to pre-selecting medications for phase 2, phase 3 trials with this? I don't see it being applied by drug companies.
Well, we got money from drug companies years ago, and Ulf got, I'm not sure from which company, quite a huge amount some years ago. So if you come up with a new drug and if you have already your safety studies, then you can, of course, go ahead with a kind of dose titrating study and also a study to identify mechanisms which may be responsible for the individual drug. So I think this has a value.
Are companies doing that? Do you know? I mean, are companies doing this before they enter into large clinical trials?
We were for quite some 10 years, we were not involved in that. But as I said, I know that Ulf was involved. I'm not sure if companies are really aware about that. So
great. Yeah, that was my impression. But thank you very much. I don't see any other questions. I want to thank you for your time and for joining us. I'm sorry you're not here in person, but hopefully that will happen one day as well. Thank you again, and thank you everyone for joining. Thank you, Rich, for helping us organize.
Yeah, thank you, everybody.
Okay, thank you.
Bye-bye.
Bye-bye.